Good evening, ma'am.
Good evening, good evening. Okay, we'll start with the class now. Can you see the presentation? Can you see?
Yes, ma'am.
So we'll start. The topic is rehabilitation. Can anybody tell me what is rehabilitation? Anything that you know? When I say rehabilitation, what does come to your mind?
Recovering.
Recovering, okay, good. Konkana, right? Was that Konkana maybe?
Yes, ma'am.
Okay, good, good. Now look at this slide. So rehabilitation. Rehabilitation, like you said, recovery, yes. So what does the dictionary say about rehabilitation? It's a noun, okay? Konkana, can you read that out for me, what you can see on your screen?
After a period of disfavor.
Okay. So what can you understand from this? Is basically the dictionary meaning, okay? What you get on the dictionary. All right? Any problem in that? Any questions? It's understood, right? It's the action of restoring someone's health. Basically, now we're going to talk about health only because we're seeing it in the point of view of orthopedic rehabilitation. Okay? So, the World Health Organization defines it as a set of interventions designed to optimize functioning and reduce disability in individuals with health condition in interactions with their environment. This is not just for orthopedic rehabilitation. This is basically for all kind of rehabilitation. Like you can see rehabilitation in the form of nowadays with the substance abuse and many other things, depression, everything, all that will come under rehabilitation. Is that understood? So coming to the main definition, can you hear me?
Yes,
Yes,
ma'am.
ma'am.
Okay, good. Rehabilitation is a multi-sectorial program of prescribed treatment for preventing or reversing the effects of ailment while returning the individual to his or her normal level of functional activity. Okay, so basically here what we are going to see is how we are going to bring back a person who has lost the normal functions, like the way we walk, we eat, okay, from waking up in the morning, from brushing our teeth to going back to sleep in the night. All the daily activities, we call it as a functional activity, okay, right from the smallest thing as picking up a pen to typing to drawing, everything, okay. So, rehabilitation is bringing back a person from the way he was because of an injury or maybe an ailment or anything. It could be like, say, a stroke patient has got stroke, got paralysis. We bring him back to normal, near normal, if not normal. Okay. So that is rehabilitation. That's a definition. Okay. So to do that, we have to have a proper way, as in we just can't just say that okay, this person is not has lost some function, bring him here, do whatever just to make it work, just to make him do that, get back the function. Okay, we have a few sets of principles. Okay, coming to the principles now. So we have 7 principles that will help with the best outcome. Okay, first is avoid aggravation. Second, timing, compliance, individualization, specific sequence, intensity, and total patient. So, what do you mean by avoid aggravation? It's simple, straightforward. Aggravation is not to make it more. Okay, to aggravate is to make it more. So, if a patient comes with a condition, say let's take an example of probably a fracture, any fracture, or maybe a fracture of the tibia or so when the patient comes to us, if we cannot do good, we should not do bad. You must have heard about that, isn't it? So to avoid aggravation is to avoid doing bad to the patient, making the condition worse. Okay, that is the most important thing we should keep in mind when we start rehabilitation. All right. Then the timing. Timing, what do you think? What's the best time to start rehabilitation? Can anybody tell me?
Ma'am, after the main treatment is done,
Main treatment, say, meaning? See, I've talked about fracture of the tibia, right? So, what do you mean by main treatment? Surgery or plaster or whatever? That's what you think, no? Do you mean that? Okay. So, timing. It's best to start the rehabilitation the first instance the patient comes to you. Okay. Rehabilitation doesn't only mean that you start like after, like when I say it's a fracture, you only start the rehabilitation of the patient after the fracture surgery is done or after the plaster is removed or something like that. See, when a patient comes to you, you cannot only look at the fracture, right? So we start rehabilitation. Say, if I said the fractures of the tibia, now we can start rehabilitating. We can start avoiding further damage. Okay, like if the patient keeps, then he'll have a lot of other problems, right? So we can ask him to start moving his ankle, start doing chest exercises. All that will start. We'll start. So the timing is right at the time of the when the patient comes to us. All right. So next is compliance. So let's start with avoid aggravation. You've understood that, right? Avoid aggravation.
Yes, ma'am.
Okay. So can you read it for me? The one who said yes, ma'am. Can you read it for me, please? Avoid
It is the
aggravation.
it is the primary concern throughout the rehabilitation program that not to aggravate the ailment during rehabilitation, knowledge of body response to injury, selection of appropriate treatment when we need to do progression in the rehabilitation protocol.
So the first paragraph you've understood, right? Till ailment during rehabilitation. Now to get that, what do we need? To avoid aggravation, we need to know the body's response to the injury. Okay. Say like if a person has had spinal fracture, you cannot shift him just like that. Okay, he needs splinting. You need to carry him in a proper way. If you just carry him just like any other person, then it will cause more damage. All right. So you need to know the body's response to the injury before doing anything. So don't do any harm. Whatever you do from the beginning, you should try to avoid aggravation. Okay. Now selection of appropriate treatment. Now you can't just treat a patient like an experiment. No, you should know what is required first. All right. So the appropriate treatment is important. The first thing that needs to be treated. All right. What first thing is what is more life threatening, what is more important for the patient, that we'll choose and we'll treat that first. Then, and when we need to progress the protocol, like say progression in a protocol, we have a rehabilitation protocol. Like we cannot start the patient if he has had a fracture, we can't tell him to run today itself. Okay. So we need to go slow. So according to the protocol, first we need to take care of the pain, then we need to take care of the range of motion, then we need to take care of his weight bearing, then he'll start walking. All right. So according to that, we have to go step by step. But if we, from the first day itself, we try to progress to another step, we skip one step and we go to the other one, it will cause harm to the patient. Okay. So we should go step by step in progression to avoid any aggravation. Okay. So now coming to the timing, like I told you, it's best that we start the sooner the better. Okay. And here we see that when we immobilize means when we keep that the part of the body at rest. Immobilize means there's no movement to it. Then we lose 3 to 4% of muscle strength. Okay. And to regain that muscle strength will take a lot of time. So it's always best that we start from the very beginning, not to lose muscle strength. All right. Now coming, so the next is compliance. Can anybody read that out for me? Compliance. Ritu Kalita, are you there? Ritu? Ritu Kalita, are you there?
Yes, ma'am.
Now read that for me. Compliance. Can you read that out? Can you read it
A
out?
patient adherence to a recommended course of treatment. It ensures that the rehab program is carried out consistently, allowing progressive recovery and improvement. It is important to inform the patient about content and course of rehab.
Okay. So from this, what do we know? Adherence is the compliance is the adherence of the patient. That means how well the patient is following the course of treatment. Okay. By adherence, we mean how well he's following, like the set of protocol that we're giving it to him. Okay. This will ensure that he's doing what he's asked to do. The patient is asked to do. He's following it correctly the way it's supposed to be done. Okay. So we also need to tell the patient as to what we are planning to achieve in the rehab program, so that when they see what they are going to achieve in the near future, they'll work better towards it. Okay, so that is compliance. That also helps a lot. That means it plays a big role in making the rehabilitation process a success. Okay, so individualization is the next one. Individualization would mean to treat the patient differently. And every individual person is different, right? So every person will react differently to a set of injury, be it anything. Okay, some people might just get a common cold and need to lie down and rest. Some might go out and work. Okay, so that's the body's reaction to certain illnesses and certain injuries. Some people have a threshold that is lower. They cannot they cannot withstand pain. Some can withstand more pain. Okay, so the rehab protocol that we are making should specifically be for a patient. So if we call it a tailor-made program. Okay, so it's like you go to a tailor and you give your measurements, and then only you get a perfect dress for yourself. The same way, we make it a perfect program for that individual patient. Okay. Next is sequencing. Sequencing would mean the type of, like I told you before, when we make a treatment protocol, we cannot skip one step. All right. We go according to what is supposed to be done in the next step. Like once the pain is gone, then we try and achieve the range of motion. I'm still referring to that tibia fracture, okay? So we need to get the range of motion, then we need the patients to lift up some weights, we need to get the strength of the muscle. All that should be done in sequence. Okay. Now next, the intensity. Intensity would be the intensity of the program that we're giving. All right. We cannot just start like this will differ with different patients. And it will differ with the area of the injury also. All right. So the intensity also, like we've made it like the program is made for the patient. The intensity also, the level of intensity also should be adjusted the same way. Okay, we should not be over. What do we say? We should not want the patient to rush into anything. Okay, and with the patient himself also should not be over enthusiastic to achieve a lot. Okay, so we should, whenever we tell them what we want to be, what we require them to achieve, we should make it clear to them that later we can achieve what maybe he wants. Probably he'll want to run. We should tell him that you will be able to run, but before that you'll learn to have to walk first properly. Okay. So the intensity also has to be set according to that patient. All right. Because the patient might be enthusiastic, might want to run, so he might do extra. We don't want that. So explaining all these is very important. Okay. And we ourselves also should not be overexcited or over enthusiastic about a patient and try to get things done quickly. It should all go accordingly. Okay. Now, the last one is total patient. Total patient meaning when when we go for rehabilitation, we have to take the whole patient concern, not just that part. Okay. So, like we're talking about the tibial fracture, if we, from the day one itself, like when I said, when the patient comes to us, we have to take care of his chest exercises, take care of the other joints, the adjoining joints like the ankle, the knee, the hip, all right? Even the hands also, because we need the hands and the strength of the hands for him to hold crutches or walkers or sticks when in the course of the rehabilitation. Okay. We also have to prepare for the patient both physically and psychologically. Psychologically meaning we have to tell them, see, like we cannot give them false hope. All right. So we'll have to tell them as to what is achievable and what is not, and what can be achieved in the long run, so that the patient is ready for what he's going to face. All right. Now coming to objectives. Can anyone read this for me? Amuna, can you read it for me now, please?
Yes, ma'am. There are two basic objectives: prevent deconditioning, rehabilitation of affected parts. Preventing deconditioning includes providing treatment for cardiovascular system and uninvolved areas of injured extremity. Good knowledge about healing process and rehabilitation methods enhance recovery of affected parts.
Okay, thank you, Mon. So, what do you mean by deconditioning? Does anybody know? Any idea about deconditioning? So, condition, the normal condition that we are in. When we say deconditioning, it's D means it's a demerit, right? So when we go back, like when we go down, it's to become it's called deconditioning. Okay, deconditioning means spoiling in a way. All right. So prevent deconditioning. Matlab prevent getting the condition worse. Okay. The objective of rehabilitation is first to prevent deconditioning. Like I told you, the moment they come, we start with cardiovascular, like chest exercise and all. Why that? So that the patient, the rest of the body is working properly. I'm still referring to that fracture of the tibia. So, like if that patient comes, we start with his chest exercises, hand exercises, other parts also we have to exercise. Okay, make him move. Like you must have seen, I don't know if you've gone to the wards or not. There are patients lying in bed who might have bed sores. Why do we get bed sores? Because the patient has not been moved. Okay, so that is also part of the rehabilitation. Okay, like we're trying to not get the condition of the patient worse. So in, he doesn't get a bed sore, that means he's in a better position, right? So if he gets a bed sore, he gets chest diseases, he gets his chest gets worse. That will be we call it as a deconditioning. If the condition gets worse, so we have to prevent all that on the first day itself. Now the second one is rehabilitation of the affected part. First, we prevent deconditioning by doing what is required for the rest of the body, and then rehabilitation of the affected part. Okay, now goals. So there are two types of goal, one is short term and one is long term. So in short term goals are set to provide an immediate achievable target. Okay, and long term goals are set to help people understand what they can expect from rehabilitation and where they can expect to be in several months. Okay, so in short term goals, say for example, you have somebody with a fracture of the fingers, okay, or the hand maybe, a crushed fracture of the hand. So, what would the short term goal be? The short term goal would be see, if it's a crushed fracture, they'll have to undergo surgery, then they have to immobilize the part. Okay, that is the affected part we're talking about. The rest of the body, we'll have to still work on the rest of the body like every other rehab program. Okay, the chest and everything. So now we're talking about short-term goal of that particular affected part. So now what we can tell the patient is the short-term goal would be just to move the fingers. Okay. After the surgery, the hand has been immobilized. Immobilized means it's been kept in plaster or it's been kept in a cast like that for a few weeks or maybe a month. And after that, you'll have to move it. So that is the short-term goal, moving the fingers, okay, bringing it to full range or getting a grip, being able to hold something. That will be a short-term goal. A long-term goal would be probably if that patient is a painter, okay, to get back to his painting will be a long-term goal, okay, to get back to what he likes to do, or a pianist to play piano, all those things, okay. So short-term goal being the immediate thing that we need from the patient that is required, and long-term like what they want to do again, but what they used to do. Okay. Now stages of rehabilitation. The first stage is initial stage. The four stages. Okay. The initial stage would be it is considered to be from the time of the injury. That means from the very beginning to the point of full range of motion. You know range of motion, no? Range of motion means to be able to move. You've done anatomy, right, in first year? So range of motion, do you know? Can anybody tell me so I know whether you know range of motion or not? What is range of motion? ROM? Anyone? Range of motion? Neha Kumari?
Range of motion is when a person has become injured in some way.
Okay, okay. So, all right. So range of motion, I'll tell you what it is. See, like the range of motion, we'll talk about a joint. Okay, the range of motion means how much you can move that joint. See, let's talk about the elbow. Okay, you have your elbow on your right hand, look at your elbow. Make it straight, that is 180 degree. That is extension, it's called extension. Okay, when your elbow is straight, it's called extension, it's 180 degree. And when you bend it, you flex it. Okay, when you bend it and touch your hand to your shoulder, that's bending it, right? We call it flexion. That is when you touch full flexion and full extension. All right, these are ranges of motion. There is a certain degree for that. I was hoping you'd know this because you've done anatomy in first year, no? So range of motion is the range of movement of a joint. Okay, have you understood now? Now if I say range of motion of a finger, like when you put your finger out, your hand out straight, okay, that is extension. The fingers are straight. When you make a fist, okay, when you bend all your fingers, they are flexed. Okay, your fingers are flexed. That's the full range of motion of a finger is from flexion to extension. Have you understood now? Understood?
Yes, ma'am.
Like even for the knee, like when you're standing, your knee is in extension. It's straight, it's in extension. Okay? And when you sit on your knees, like when you bend on your knees, it's 90 degree. And when you sit on your foot with your knees fully bent, that is full flexion of the knee. Okay? I hope you've understood that. Alright? Now, so initial stage would be from the time of injury till the patient has full pain-free range of motion. Pain-free range of motion means the patient is able to move that joint without pain. Okay? Understood? But the functional level of the initial stage will be poor. Now the intermediate stage, it is considered to be resumption of the normal activity of daily living. Activities of daily living, like I told you, right from the beginning, right from the morning when you wake up, from brushing your teeth to going back to sleep. Okay, those are all activities of daily living. Eating, walking, writing, okay, watching TV, all are activities of daily living. Okay, so once the intermediate stage would be the stage when the patient can do all these activities. Okay, like he can brush himself, he can go to the toilet, he can take a bath by himself. All right. So the functional level here is fair to good. That means he is functional, can do things. Now, advanced stage. Advanced stage is considered to be the commencement of functional activities related to profession and skill. Okay, so advanced stage would be, say, if you're a student. Okay, so now what your advanced stage would be being able to go to college. Okay, being able to sit and study, being able to get into normal activities like walking up and down the wards, okay, walking back to your hostel, that would be your advanced stage. All right, now you're returning to job. That's the last stage. It involves full participation in the profession and skill job. In your case, it would be like running, playing basketball, getting yourself involved in games. Okay, you like have dance competitions, you can join in that. That means you're back to being normal. All right. Have you understood that?
Yes, ma'am.
So now those are the stages of rehabilitation. Once the person has returned to job, that means rehabilitation done. Okay. But what we need to do more is examination and assessment. Even after everything is done, we have to examine again. We have to do some more assessments to see that all the goals are achieved or if the patient needs more. Okay. Even if we do the examination assessment also so that we can help the patient even better. Like I told you, if the patient like if the advanced stage you have started, like in your cases you've started going to college, going up and down and all, but then you want to get into a dance competition. Okay, if you're not ready for it, you're not in the stage of return to job, then you won't be able to do that. Okay, so we need to assess again, see whether you'll be able to do that also or not. Okay, so assessment is required at every stage, and it also helps in maintaining records. Okay, now rehabilitation is a teamwork, so you must be knowing that. So we start with general physician, surgeon, nursing staff, psychologists, physiotherapists, occupational therapists, prosthetists and orthotists, special educators, speech therapists, audiologists, vocational trainers. Okay? Any confusion about any of this? You know what all these people do, right? Does any of the profession look unfamiliar to you? Narang? Narang, are you
Yes,
listening?
ma'am.
Do you know everything? All these professions?
Ma'am, prosthetist or
You do know prosthetists and orthotists, right? Okay. These are the ones who make you these artificial limbs and the splints. We have this in our hospital itself. Okay. Have you understood? It's they make those belts. They make the artificial limbs, the hands and the legs for the amputees. Okay. Understood now? Anyone else with anything that you don't
yes,
understand?
ma'am.
Anything else you don't understand?
No, ma'am.
So read for me Rehabilitation Council of India. Nara, read the page, please.
Yes, ma'am.
Okay, I'll read it out for you. The Rehabilitation Council of India (RCI) was set up as a registered society in the 1986. On September 1992, the RCI Act was enacted in the Parliament and it became a statutory body on the 22nd June 1993. The Act was amended by the Parliament in 2000 to make it more broad-based. The mandate given to the RCI is to regulate and monitor services given to the person with disability, to standardize syllabi, and to maintain a central rehabilitation register of all qualified professionals and personnel working in the field of rehabilitation and special education. The Act also prescribes punitive action against unqualified persons delivering services to persons with disability. Okay. Why we are reading about this Act is there is a Rehabilitation Council of India. You must be knowing that. Okay. It was formed in 1986. This council has helped, has categorized the rehabilitation professionals. Okay. For every rehabilitation professional, there's a proper course, there's a proper degree for it. Okay, and nobody can just come and just tell you that they can fix this, fix that. It's not done like that. Okay, so this act has been the RCI has been formed in 1986 to take care of that. Okay, so that nobody can just come in between and do whatever they feel. So now the different fields of rehabilitation, these are the ones that are common, but there are more that have come up these days. Okay, cardiopulmonary, orthopedics, sports rehabilitation, neurological rehabilitation, obstetric and gynecology, and pediatrics. All right. So after all this is done, now we know we've considered the patient's affected part. We've considered the patient's whole body as a person. Now we have to consider the psychological part of the patient also. Why do we need to do that? Can anybody tell me why do we need to take care of the psychological part of the patient? Okay. So now you understand whenever a person is ill, like with a long term problem, with a long term disease or with an injury, they are basically they're depressed, mostly all of them. Okay. So we need to consider this factor because if the patient is depressed, if the patient is ill-informed, especially like when they get into a, they become sick, they feel like it's all over, then we cannot help them, we cannot convince them to work for themselves. Like when we rehabilitate a part or we rehabilitate the person himself, if the person is not giving any inputs, if the person is not trying from themselves for themselves, it's very difficult for the rehabilitation team to help the person. Okay, so we have to consider the psychological part of the patient, and mostly when an injury happens, especially like if the person is young, is very active, suddenly some accidents happen, something happened, and he has an injury and he's now bedridden. So that is very depressing. It becomes very difficult for the patient to cope with. Okay, so we'll have to consider all the condition of that patient at that time. So what we know is the stages of grief that have been given by Kubler-Ross in 1969. We generally see this. First is denial, then anger, then depression, then acceptance. Okay. Denial means when the patient does not believe that the injury is severe. Okay, some like they say, no, it's all okay. We can take care of it at home. Okay, it's not that big a deal. That will spoil his condition. Okay, some would be angry. We might be the patient at any stage. Okay, it could be at a denial stage, at an angry stage, anger stage, or a depression stage. And if it's acceptance, then it's very well and good for us. So when the patient is angry, okay, generally they'll come out at you very angry. They'll want to. They'll say that all this whatever you're doing is bogus. We don't want to do things. We see a lot of such things. Okay, patient getting angry. We should not take it to heart because we should know that they are undergoing all these stages of grief. Okay. Next comes depression. You must have seen some patients who are really ill, do not want to talk, do not want to drink water, do not want to take medicines. This is all signs of depression. Okay. They do not want to participate, they do not want to be there for the treatment. Alright. Now acceptance. Once the patient begins to accept what they're having, what the condition is, that is when we can we one in one way we can teach them, like we can help them if the patient is positive about it. But there are some cases when the patient has taken it like, okay, I have this problem and I don't want to do anything about it. That is also a problem for us. Okay, so we'll have to work with the patient through all these stages. So we'll have to be really patient when we are giving rehabilitation. We have to, rehabilitation as it is a long process and it's an everyday thing. So to just see the patient today and let the patient go is not our work. Okay, we'll have to start from the very beginning, stay with the patient months on, even years for sometimes. Okay, so they keep coming to you, keep coming till they feel better. So we'll have to, through all these stages, we'll have to identify the patient through these stages and try to work with them throughout these stages. All right. So you've understood denial, anger, depression, and acceptance. Now these are the factors, the psychological factors that will help in getting the rehabilitation goals sooner. Like I told you, the denial, the depression, and all that will slow down the rehabilitation process. But there are some things that will help in the rehabilitation process also. One is education and communication. Once, like the patient is educated, you're able to communicate. You're able to talk to the patient properly. The patient is able to understand you. Then that helps in getting better results. Okay, goal setting with the patient, we have to set some goals with the patient, that all that will help in uh, making the rehabilitation process fast. All right, can anybody read the conclusion? I think this is the best part for you. Conclusion. Nazim, Samin,
Yes, ma'am.
read the conclusion, the best part.
Yes, ma'am. Ma'am, rehabilitation should not only target on injured extremity, focus on total patient conditioning, better prepares the patient physically and psychologically to participate in the mainstream of society as soon as possible, safely, efficiently, and effectively.
Good. So throughout this, what have we learned? We've learned that rehabilitation should not only target the injured part. Okay, we should focus on the total body. Hmm? And the next is we have to prepare the patient physically and psychologically to participate in the mainstream. Have you understood what we've talked about? Mining, mining.
Yes, ma'am.
Have you understood?
Yes, ma'am.
So what is rehabilitation? What is rehabilitation? Mining? Say it in your words, it's okay. What have you understood?
Ma'am,
Anything, anything. Say it in your own words, whatever you understood, it's alright.
to help the patient regain its normal psychiatric condition.
Not only psychiatric, physical and psychological, okay?
Ma'am.
Alright. So if you get a question of, say, 10 marks, can you write about rehabilitation? Will you be able to write about rehabilitation if you get a 10 marks
Yes,
question?
ma'am.
Yes, good.
Yes, ma'am.
Okay. So, does anybody know about rehabilitation, nursing rehabilitation? There's a rehabilitation nurse. Do you know about it? There's a course for it. Do you know about it?
Yes, ma'am.
So, anybody interested? Not thought about it. Okay. Chal. Anyways, so thank you, class. I think that's it. I hope you can answer everything now. So thank you, class. I'll go now. Bye bye.
Thank you, ma'am.
Have a good
Thank you, ma'am.
Thank you,
bye.
ma'am.
Thank you, ma'am.
Bye bye.
Ma'am.